coming to the series of webinars which Philips has been doing. Very appreciative of that. And the focus has been on basics of echo. So I will be focusing on something called as normal variance seen on echo, and also something about what is called as true view 3D imaging, where it gives you structures which is as close to the anatomical appearance as you can see. Now, normal variants are something which you have, you'll be probably seeing on a routine basis, and it gives you problems now and then, some sort of heartburn. You are not sure whether it is normal, abnormal, whether to report, not report, or what exactly it is. And sometimes, even if you know, you're not sure what to do with it and whether you're really correct about it. So let's look at these normal variants. So one is, if you are okay, sorry about that. So let's look at these chambers now. So these normal variants, we can go chamber by chamber. So one would be the right atrium, and that is the chamber which gives the most problems and the most sort of findings. And then we have the right ventricle, and then we move to the left side, and I've categorized something called as others also. Then let's look at right atrium. So what are the structures which we should be aware of in right atrium? You have the Chiari network, and then you have the eustachian valve, the Crista Terminalis, and then numerous types of lines and leads, and then the interatrial septum, which I'll take later. I'm not categorizing inside the right atrium. And then you have the pectinate muscles, and then the fatty material. Now, let's look at a little bit of the anatomy. And this is how the actual anatomy looks like. So these are not from a live patient, but a simulated real tissue. And you can see the anatomy of the IVC, and then you have the coronary sinus. So these are the two structures which you have to be very, very carefully be aware of. They are very close to each other. And many times you have these structures like the eustachian ridge or the Chiari network, which comes from the IVC, and there is the Thevesian valve also, which is sometimes seen at the coronary sinus. So let's focus on the eustachian valve or the eustachian ridge here. Now, the eustachian ridge is a muscular type of ridge. It's primarily a valve which was there at the fetal time, and it is supposed to regress. And then again, here in this image, you see the coronary sinus, and then you have the intervening tissue, and that is the eustachian ridge over there. And then when it does not regress, when it does not involute, so then it will be a very elongated structure depending on how the structure is. It can be variable from person to person. And how do we sort of define eustachian valve? So it is a ridge of variable thickness. It is a remnant of the fetal structure, sorry about the spelling mistake, that directs oxygenated blood to the foramen ovale, and this flow goes into the LA, and that is how it does its job in fetal life. And once you're born, the regression of this structure takes place, and it is supposed to go away, but when it persists, that's when you call it as the eustachian valve. So how does it look? So those of you who are not familiar with the TE, so these are TE images at the top ones, and it is especially seen very clearly in the TE, so that is why I have focused on this. So there is something called as the bicable view, and you see the structures over there, the left atrium at the top and the right atrium below, and then you have the SVC on the one side and the IVC on the other side. And then if you look at the IVC coronary sinus, you see two openings over there. And in between those two openings, you see this prominent fold, that is the tissue which is sort of projecting out. Normally, you don't see this so prominently, but here you see it is very prominent, and it doesn't really move that much. So it is sort of termed as ridge when it doesn't move that much. On the other hand, if you go to the image on the right side, you can see that it is very mobile, and that is when you call it as valve. And this can be again variable. You can see it very small, or it can be very elongated also. And the image below is the transthoracic image, and that's how it looks like in the right atrium, and it can be mistaken sometimes for vegetation. It can be mistaken for a lot of even thrombus, things like that, which can which can mimic pathologies. Then these are 3D images. This is from the same data set, and you can see the arrow below, which shows a very thin sort of flimsy structure undulating back and forth, and it is directed towards the small foramen ovale, which you can barely see, where the other arrow points towards. Now let's look at the structure in a different perspective. Again, it's the same data set rotated, and this is the interatrial septum with the patient standing up, as you have to visualize that. And the interatrial septum is seen from the right atrium. You have the SVC on top and then the IVC below. And then the arrow below shows that structure, which is undulating, which is sort of leaf-like. That is the eustachian valve, and that's how it actually looks like. But on 2D, it looks like just a small sort of a thin structure, but the flap-like, valve-like structure is how it is seen on 3D. And if you look at the data set, which is slightly sort of rotated, and suddenly you can see two orifices. You have the IVC, and then you have the coronary sinus, and in between you can see that the eustachian valve is very clearly seen over there. So this is how the appearance of the eustachian valve is on 3D, and this is the actual anatomy, how it looks like. Now, there is another type of variant which is called as the Chiari network, and this is again, some people term it as the again the eustachian valve, which is very prominent, and then this is fenestrated. It is sieve-like, so it is web-like, and it is a remnant of the right valve of the sinus venosus. And again, it is failure of resorption, failure of involution, and it is very mesh-like, and you can see that it can appear sort of multiple slithery structures seen within the right atrium. So this is the Chiari network. Now let's move to another structure. So this is again commonly seen, and this is called as the Crista Terminalis. So you have in the image above, you can see that there is a web-like, multiple sort of trabeculations over at the top, and you have a smooth structure on the other side. So this Crista Terminalis is the one in between, which separates the smooth from the trabeculations. And again, you see the image below, that cord-like structure as it sort of snakes its way across the right atrium. So how do we sort of define it? A Crista Terminalis, it separates the right atrial appendage from the smooth surface of the right atrium. And it is a smooth, muscular, thick ridge, crescent shape, extends from the right side of SVC and IVC and continues to the right atrial appendage. Then how does it look? So you can see the one on the left side, the top one. So that is the transthoracic apical fourth chamber, and the arrow pointing shows a prominent sort of mass-like structure. So this can be mistaken for a tumor, mistaken for a thrombus many a times. So one should be aware. So this is the usual location where it is seen, and you can see that the image, which is frozen, also shows very clearly that prominent structure. On TE, you can see that fold where the SVC opens up. So this can become very prominent sometimes. And the one below you, it has been inverted. Just to give you an idea of how the actual anatomy in terms of the echo correlation, you can see that the arrow points towards a cord-like structure over there, where you can see the where it sort of moves in a crescent sort of shape direction, and that is how it actually looks like. Next is you have a small set of patients coming in sort of in certain hospitals. And when one is doing, depending on the type of surgery that has been done, you can see the structure where it looks very prominent. And this is the point where the suture lines, you have the native atrial structure, and then you have the transplanted heart. So in between, you have this prominent suture line. So this can be very, very prominent. And this is another variant. Then you have a lot of lines and leads, which you see very frequently, especially these days when you have a lot of people put up with lines like you have the dialysis catheters, you have the chemo ports of cancer patients, and in a hospital, you see these patients in critical care units, in the ICU, the CCU. So you have to be aware of this. It is easy to sort of identify because you know that there is a visible line which is there in the neck, in the upper chest, and that is how you associate. So one has to be careful when you see this and then try to correlate with the patient externally. Then the right atrial appendage, not much of a problem, especially in transthoracic, because you don't see this right atrial appendage so well in transthoracic, but in TEs it can be seen. And here again, you have something called as pectinate muscles, and these are sort of ledges or ridges of muscle, and it sort of goes in a very intertwining sort of way, and when it becomes very prominent, it can look very thick, and again, it can mimic some masses, and it has often been compared to the teeth of a comb, and this is how it actually looks like. And this is again an image of a transesophageal echo. You can see the right atrial appendage over there, and a very prominent set of pectinate muscles. Normally, even in TE, you don't see it so prominently. This is just an unusual patient who had this, and it's a good way of sort of telling how it's showing how it looks like. And these are pectinate muscles, not to be mistaken for a thrombus, not to be mistaken for a tumor, which is the usual assumption. And 3D images, sort of blurry, but it gives you some idea of sort of how it looks like on the 3D. You can see these muscular ridges as it goes, but you can see very clearly as you can look down into the right atrial appendage that there is no pathology, no abnormal structure. It is just that there is a very prominent pectinate muscle over there. Then you have another set of variant which you see. So this is the lipomatous cell, and the lipomatous cell, wherever it is seen, is usually very bright, very echogenic, and depending on where it gets deposited, it is called as lipomatous hypertrophy or lipomatous deposition. So here you can see that it is a tricuspid annulus, not very frequent, but you do get it once in a while. And you can see that deposition takes place at the annulus, and the annulus looks very thick and very prominent, and one has to be careful about this. So generally, the lack of pathology elsewhere, and then the fact that it is at the annulus and very bright, that tells you that it is lipomatous. Now, the anatomy again, I'm emphasizing, so and its relationship. So here you have the coronary sinus, and then you have the tricuspid valve. So the tricuspid valve, coronary sinus has very close relationship. So that is something which you have to be very careful depending on which view, wherever you see it. So these two structures sort of go very closely to each other. Now the coronary sinus, per se, it would not be good to call it as a normal variant because it's a regular structure. It's only when you sort of take sort of views which are off axis, or when you go a little posterior, it tends to be seen, and then you see that prominent echolucent area, and this can be mistaken for ASD, and that is something which you have to be aware of. So the coronary sinus opens into the right atrium, and it is very close to the tricuspid valve as seen over there. So to summarize, as far as right atrium is concerned, so you have the Chiari network, which you've seen, the station valve, the Crista Terminalis, the catheters, pacemaker leads, then the lipomatous cells, the interatrial septum I'll come to later, then you have the pectinate cells, the right atrial appendage, not generally seen on transthoracic echo, but can be seen on TE, and then you have the lipomatous deposition in the tricuspid annulus. Let's move to another chamber, the right ventricle. So few structures when you compare it to the right atrium. So you have the moderator band, and then you have the muscle bundles, tuberculations, and then again you have the catheters and pacemaker leads. The right ventricular anatomy divided into three parts. You have the inflow, that is the tricuspid valve, And then you have the heavily trabeculated apex or the cavity. And then you have the outflow, the smooth part which is there. And then the moderator band occupies a very prominent place in the right ventricle. And here you can see the thick band, which is very prominent. And usually you see the moderator band starting from the interventricular septum, and it goes towards the base of the anterior papillary muscle of the tricuspid valve. And that is the course it takes. It has an oblique course from the interventricular septum towards the RV free wall and its association with the anterior papillary muscle, and a very prominent structure. And it is of great use in congenital heart disease because it is always associated with RV, so that you know that if you see it, that it is the right ventricle and that it's a marker, it's some sort of a characteristic feature of the right ventricle. Sometimes it can be very hypertrophied, it can look very thick, very prominent, again, not to be confused with any pathology. And on T, this is how it looks like. You have the moderator band, which is seen over there, going in an oblique fashion. If you go a little sort of off axis, you turn your probe a little bit and then you make it a little anterior in the transthoracic echo, you start to visualize the trabeculations. So you can see a lot of trabeculations, especially towards the apex, and you can see towards the RV free wall also. So this can be a problem again, especially when you have a dilatation of the RV and when you have a patient where you're supposed to look for any RV thrombus. So this can become a problem. So just be aware again that these trabeculations can sort of mislead you thinking that it is a mass. It could just be the trabeculations per se. Then you have the catheters and leads also. So those which extend and go into the right ventricle. So usually these are the pacemaker leads, and far and few, not seen so frequently, but seen in the setting of a critical care or during perioperative. You have the pulmonary artery catheter, which you see in the image below. So this also can be visualized within the right ventricle, and it goes into the right ventricular outflow tract across the pulmonary valve. So the pulmonary artery catheter is another structure which you should be careful when you are seeing something like that in the right ventricle. So the right ventricle, it has the moderator band, it has muscle bundles, trabeculations, and then you have the catheters and then the pacemaker leads. Now, let's move on to the left atrium. So the left atrium again has a reasonable number of structures which you should be aware of. You have suture lines, and then the fossa ovalis, which I will talk to you later, and then the mitral annulus, which is part of the left atrium, and then you have the coronary sinus here again. And then very, very important is that ridge between the left upper pulmonary vein and then the left atrial appendage. And then again, the interatrial septum involvement, which will be dealt later. And then the left atrial appendage and the pectinate muscles seen in the left atrial appendage. So let me first finish with this, the suture lines seen during transplant. So similarly to what you saw in the right atrium, you see a similar structure in the left atrium also. So this is the point where the suturing has taken place between the transplanted heart and the part of the native tissue of the patient. Then you have the mitral annular calcification. So you have this very bright calcific mass. So this is not very easy to miss. It can be variable depending on how much the annulus is involved. Sometimes you'll see just a small portion of it. Here you can see that crescent shape at the top image. That is the short axis at the mitral valve level. And you can see that it is distinctly separate from the posterior mitral leaflet. So many people assume that it is the posterior mitral leaflet, so you should be careful. So using the short axis and seeing the posterior mitral leaflet and separating it from the posterior mitral leaflet in this view will help you to tell you that it is the annulus which is calcified, and it can be extensive or it can be just part of it. And in the Passon long axis image, as you can see below, and it is an end-on appearance here, so you can see just one prominent calcific mass over there. Again, you should not associate it with the posterior mitral leaflet, and you confirm it by looking at it in the short axis view. So this is the mitral annular calcification, especially seen in the elderly. Now, coronary sinus, if you continue that anatomy from what you saw in the right atrium, you saw the opening previously. Now I have opened it a little more. You can see that it courses in a transverse fashion as it crosses across the atrioventricular ridge over there, the groove, and then you can see that prominent lucent, translucent area. So that is the coronary sinus, and in biventricular pacing, you can sometimes see the lead going into it, and when the coronary sinus is dilated, whenever there's a pathology associated with which will look very, very prominent here, and you should be careful about this. So don't think that it is some sort of a cavity. So this would be the coronary sinus. And how does the coronary sinus look like in the anatomy? So you have the left superior pulmonary vein, which you can see in the top image where it is labeled, and then you have the left atrial appendage. Ignore that left inferior pulmonary vein. We are not interested in that. So just focus on the left superior pulmonary vein and then the left atrial appendage. You can see the prominent fold of structure. So that is the Coumadin Ridge. So it got its name because the fact that it was earlier associated with clot, so people thought it was a clot, and they were treated with the Coumadin derivative, so that's how it got its name as Coumadin Ridge. And what is it actually made of? So it's a band-like embryological remnant, and it is between the left superior pulmonary vein and the left atrial appendage, and it is formed by the coalition of these structures, and it forms a tissue fold. And what it contains as far as the surgeons, the anatomists are concerned, so it would be the ligament of Marshall, the autonomic nerve bundles pass through that, and you have a small atrial artery also, so that which you don't see, but it just tells you what it contains. And on transthoracic, you can see that, again, you don't see this very prominently in transthoracic, and very unusual sometimes, and this is one of those patients where it is very prominently seen. And it is also called as the Q-tip sign. So this is more of an American sort of slang, where Q-tips is a earbud, and typical of earbuds, you have the narrow sort of stick, and then you have the cotton sort of which bulges. So that is supposed to be the similarity. So in literature, they term it as the Coumadin Ridge or the Q-tip sign. So don't confuse it with some pathology. Don't confuse it with some tumor or thrombus, especially when the left atrium is dilated. And this can look even more prominent on TE. So I have put an image of a earbud, so that's how it looks like. So you can see that bulging tip, and then you have the slender portion. And especially when you have the left atrium dilated, you have a lot of sag, and then your suspicion of thrombus is very high. So this should not be interpreted as thrombus. So one has to be careful. And again, emphasizing on the anatomy, you have the left upper pulmonary vein, and then you have the left atrial appendage. So that is where this structure is seen. Now, the left atrial appendage, just like the right atrium, has pectinate muscles. So you're more likely to see pectinate muscles of the left atrium rather than the right atrium. And this again is better seen on TE. And you can see that it is not so very clearly seen here. But let's look at the 3D part of it. So this is a technology called as TrueView. So it is nothing but 3D imaging. So that is the level of sophistication of how 3D has become now. So this is actually truly sort of reflecting what could be the actual anatomy. That is how it looked like if you open up the left atrium on the surgical table. And that is why it is called as the TrueView. So what you see here is the pectinate muscles. So what you saw in the previous image is actually a 2D where you don't see it so well. But once you acquire it in the 3D, and then you use something like a light source, you can see the different shades of how it looks like in the bottom image when you compare it. So it's like you're holding a torch and sitting inside the left atrium, and you're looking at the left atrial appendage. So you can see the series of structures. so comb-like structure. So that is how the pectinate muscles look like. So it gives us very clear confidence that it is not a mass if you do see it on 2D, and you can easily separate it out by using this 3D TrueView application. So left atrium. So just to summarize the chamber, so you have suture lines, you have the fossa ovalis, which will be dealt later, calcified mitral annulus, coronary sinus, which you have to be careful, the ridge between the left upper pulmonary vein and the left atrial appendage, very, very important, which you should be aware of. And then the interatrial septum will be later, and then the left atrial appendage pectinate muscles, especially T. So that is something which you'll be seeing it quite often. So you should not confuse it with the clot. So try to separate out. Now the next chamber, left ventricle. So left ventricle, few structures compared to the other chambers, especially when you compare it with the atria. So you have something called as the false cords or the false tendons, and then you have the papillary muscles, which can be seen in sort of in different angles, and it can appear like a mass, which you should be careful. And the left ventricular trabeculations also can look very prominent. First, let's look at the LV cord of the false tendon. So this is how it looks like, the LV cord. So that bright structure which sort of crosses the left ventricle cavity. So that's the LV cord. And you can see it in two different views. So this is how the actual anatomy looks like. And you can see the trabeculations in the background. But what you see on 2D, this is how it is. So here you can see that small sort of slender structure prominently seen crossing the left ventricular cavity. This can look very big, it can look very thick, it can look even thinner. So again, it is nothing but the LV cord or the false tendon. So again, it's a variant. So there have been some literature which has been published which says that it is sometimes associated with some arrhythmia. So whenever there's an arrhythmia and when you see this, there is the EP person would be interested whether this is the one which is causing it. But otherwise, you just sort of see it and you don't really sort of get too worried or concerned about it. And on T, that's how it will look like. So you have the LV cord or the false tendon. Then a little focus on the papillary muscles. So generally we're all aware of papillary muscles, we know that, but we don't generally see it so well. But sometimes because the window is so good or maybe your angle is in a different way, you tend to hit the papillary muscles and suddenly it will look very prominent and very sort of unusual for you. So the anatomy, the course and how you trace it tells you that it is a papillary muscle. So generally it will go attached to the free wall, it will have the chordae and then it has a continuity towards the leaflet. That's how we know it is papillary muscle. And these papillary muscles can become very prominent, very sort of thick, sometimes due to some aberrancy. You have aberrant attachment and in hypertrophy cardiomyopathy also. So papillary muscles also can sort of mislead you sometimes. Then the trabeculations of the LV. So just like you have trabeculations in the RV, RV is more trabeculated. That is very clear. LV is less trabeculated. But in some patients, the LV also can show increased trabeculations and especially towards the LV apex. LV apex is a big, important structure for us. We know that, especially when it comes to trying to find out whether there is a clot, that is a common sort of focus. And then in apical hypertrophic cardiomyopathy. So, and you have the artifacts also, which can cause you problems here. So the LV apex is something which you should be careful. So again, here you have a lot of trabeculations, which can be seen in some set of patients. So that is something which you should be careful. And here in the TrueView image, you can get to see it a little more prominently. You can see that it is as close as you can get to see how the trabeculations look like. And you can see that closer towards the LV apex, you can see more sort of trabeculations. So it is not a mass, it is not a thrombus. And that is how the TrueView image sort of gives us a good perspective of how the actual anatomy looks like. And when in doubt, we can always use the applications that are available to us. So you can have the contrast echo. So the contrast echo sort of separates out the mass from the tuberculations. And this is of great help and great boon, as you can see here. Now, whether it is non-compaction, that's a different area. I will not go into it, so I'll not focus on that, but because that's a different sort of specialty altogether. But here, what I'm trying to emphasize is that you can get a lot of tuberculations in the LV apex, and it can be mistaken, and especially when you have a coronary artery disease where the apex is infarcted and you have an akinete apex, you can mistake it for a thrombus and continue to treat it. So if you do have the option, use contrast, and that sort of tells you that it is not a thrombus and it is more likely to be tuberculations. So the left ventricle, you have the false cords, and there you have the false tendons, which is also termed, and then you have the papillary muscles, and then the prominent left ventricular tuberculations. Now let's look at septum. So I have created this as a separate entity because even the septum can sort of give you some confusion sometimes. What should we know of? So let's take the interatrial septum. That is the structure which we need to focus upon, and that is where we have a lot of issues. So this is how the interatrial septum looks like. So you can see how it looks like both from the right atrial side and from the left atrial side, and the thin sort of mobile bulging structure, which is very thin and a little mobile, that is the fossa ovalis. And that is the actual anatomy, the description of the interatrial septum. So the thin mobile structure, the one which is in the center, is called as the fossa or the floor, and it is oval shaped, it is ovalis. And the surrounding thick structure is the limbus of the interatrial septum. And you can see that bulging back and forth, and that is how the actual normal movement of the fossa ovalis is. On transthoracic echo, it can cause confusion, and especially when you're new to it, or sometimes even when you've been told, look for an ASD, and this dropout over there can be misinterpreted as an ASD. So that is the area where the fossa ovalis is. It's a very thin structure. That is why you have this dropout, because the beam has to travel all the way from the apex, and in the far field, it's a thin structure. The beam travels parallel to the fossa ovalis, and that's where the dropout happens. And this can be misconstrued as a defect, and you should be careful about this. Now, the fossa ovalis, when it has an opening, it is the patent foramen ovale. So the PFO is always associated with the fossa ovalis. This is how it looks like. It is like a flap, two flaps which have failed to fuse, and that opening is what is called as the patent foramen ovale. So there's no true defect. It is just that the two flaps which have failed to sort of join together, fuse together, and that opening is the patent foramen ovale. And you can see the patent foramen ovale from the right atrium. And this is on the left atrial side. That is the true view image as to how the patent foramen looks like. Very small, tiny structure. And then you can see that every time the cardiac cycle sort of goes through its phases, it gets covered. And that's how the patent foramen ovale looks like. Then the flow across the patent foramen is not seen in most of the patients, but you can see it provided you get the right angles. Especially the subcostal view is good to look for any flow, because you're now more perpendicular to the structure and you're more likely to catch the flow much better, because it's a very thin flow and it can be intermittent sometimes. And that turbulence which you see across where the arrow is pointing is where the patent foramen ovale is. Then another type of variation, it can be called as the atrial septal aneurysm. So this is a very prominent atrial septal aneurysm. Sometimes it will be much less obvious than what you see here. So this is again seen towards the right atrium. So you have different types of atrial septal aneurysm. It can be towards the right atrium bulge. The bulge can be towards the left atrium, or it can go both ways, or it can go on either direction equally. So there is a classification of that also. So here you can see that there is an atrial septal aneurysm. If you do see it, it has to be mentioned in the findings, and especially in patients who have had strokes, you can have small thrombus lodged in this atrial septal aneurysm, the pouch-like area, especially when you have the atrial septal aneurysm, which is bulging towards the right atrium, and then the concave portion faces the left atrium. That is a patient of high risk of having a thrombus, and if there has been a stroke, your focus should be on looking at this particular area and see whether any pathology is there. But generally, if you do see it, you just report it and say which side it is, and that is it. Now, the atrial septal aneurysm is associated with frequently, it is associated with patent foramen ovale. So try to look for a patent foramen ovale. Again, it can be difficult, but you can sort of try whatever you can if you do see it. And if the suspicion is there, of course, you can always ask for a transesophageal echo. Subcostal view, again, is a good one. So as you can see the image below, you can see that small intermittent flow which you see. That is the atrial septal aneurysm with the patent foramen. That is a flow which is seen over there. Now, another variation, which you don't see quite often, but now with a lot of focus on the PFO closure and the fact that you have the 3D, which gives you much better perspective. And this is something called as the interatrial septal pouch. And this is very nicely, spectacularly seen in this particular patient. And especially, you won't get to see these images in regular 3D. So this is, again, the true view 3D image. And you have these three images. So one on the top is the left atrium. And that is the interatrial septum seen from the left atrial side. You can see that pouch looking very distinctly, and the images below are the 2D images. That is how it looks on TE, and that's how it looks on 2D. But when you see it on 3D, that is how you see it on the left atrial side. Now, when you see it from the right atrial side, you can see the SVC at the top, and then you have the IVC barely seen. Here you don't see that pouch. It is primarily seen on the left atrial side. So let's take a closer look as to how it looks. And this is again from different angles. Again, it gives you some spectacular images. It is something which was never seen before, which you could never achieve before. And these true view images truly makes it worthwhile in how one can look at these atrial septal sort of defects, the pouches especially. So look at the top one. You can just see the slit. You're looking at the interatrial septum right at the top, and you can see that crescent sort of oval-shaped structure is the SVC, and the septum on this side is the left atrium. That is where it is prominently seen. On the right atrial side, the septum you don't see. And then you go a little closer, you can see the pouch, and then you can actually sort of use the light source. I can sort of shine the torch inside, and now it truly looks like a pouch. So this is how the interatrial septal pouch looks like. And how it is of concern to us is that it can sort of cause a problem in terms of having a thrombus there. And that's the anatomical variant, and then the pathology that can be associated, and an emphasis on how the true view sort of gives you some images which was never seen before. Then the other pathology which you should not, pathology, I should not use that word, is a variant. So it is the variant again is the lipomatous deposition. So you can get this deposition now. Earlier I showed you deposition in the tricuspid annulus. When you see a very thick interatrial septum that is in the limbus area, very bright and very echogenic, you have to assume that it is more likely to be a lipomatous deposition. And this again is seen very prominently in transesophageal echo. And it has been compared to the dumbbell, where you have the thin middle fossa ovalis, and you have the thick structure on either side, the limbus area, and the bright structure. You can see that it is causing some artifacts also as some sort of reverberations. So that is how the interatrial septum, when it is thick, when it is sort of has this lipomatous deposition, especially these structures, this sort of deposition seen in as one sort of ages. You see more in the elderly people. Now coming to the last category, so these are miscellaneous structures. So these I've termed it as others. So let's look at the valves. Now you have the aortic valve, which is a structure which you should closely focus. And this is how the aortic valve looks like on true view. So let's look a little more closely as to what pathologies can be seen on the aortic valve. So one is termed as Lambel's excrescence. So this is something you have to be aware of. And this is described as a thin, filiform, undulating, can be single, can be multiple, and it is having an independent movement. It doesn't sort of relate to the cardiac cycle, and very, very mobile. And where is it seen? At the point where it coapts. That means at the point where the leaflets meet each other. So that is where it is seen. So that is the characteristic feature of Lambel's excrescences. And it can be as thin as 2 millimeters. That's how it usually is. And sometimes it can be really big. It can be as big as 20, very few. And those are termed as giant LEs, the Lambel's excrescences. So how do these appear? So you have to use the zoom feature here. And this is especially important when patients are being sent for stroke evaluation, and whether it is transthoracic, very low likelihood that you'll be able to see, but especially when you're doing a TE, you have to use the zoom feature. And these are really prominent ones, and most of the times you'll see just a small, barely visible structure, and it can be mistaken for vegetation. Do not think of it as a vegetation. It can be a problem when you have a clinical scenario like that, and that's a problem where you need additional imaging modalities. But this is how the Lambel's excrescence looks like, and you can see that it is attached to the point where the leaflets meet. So it's not coming from the body of the leaflet, and it is usually seen on the LVOT side. Now sometimes it can be seen on the aortic side also, when it sort of moves out, and then you can see it appearing a little prominent on the aortic side. And on the short axis side, you can just see barely that it is attached to the margins of the leaflets. So Lambel's excrescence is something which you should be aware of. And then 3D images, not really great, but you can sort of see it from the LVOT side. You can see that the attachment is at the margins, and then the aortic side, you can see, barely you can see and visualize it. And then you can see that in the lower image also, where it is coming from the coapting area. And another patient, little less obvious, but again very prominent here. So this patient was being evaluated for a stroke. So again, if you do see it, you have to report it. So it has been associated with strokes. It is up to the clinician as to how they will associate it with, but it has its role and it has its importance. This is with the aortic valve. And again, this is a frozen image, and you can see that it's a very thin, slender, linear structure which projects into the LVOT. Then coming to the last few slides, and here you can see a few more sort of entities where you can mistake it for a pathology. So this particular one is the epicardial fat, and epicardial fat is commonly confused with the pericardial effusion. And what it really separates is you have to increase the gain a little bit and see for any granularity. And moment you see a little bit of granularity, and you can see that it moves with the cardiac cycle, then it is likely to be epicardial fat. And in isolation, when you see it anteriorly, you are less likely to sort of conclude that it is pericardial effusion, and more likely it is epicardial fat. And then usually it's seen on the right side, especially the right ventricular side. And you can see the image below, that is a short axis where you can see the thick pad of fat. It has its own importance. It's used as a marker of atherosclerosis. But two important things: you should not mistake it for an pericardial effusion. And if you do see it, if you're really keen on it and if you see it very clearly, you can make a mention in the findings that you see a prominent pad of epicardial fat. And again, it is up to the referral doctor or the clinician who can decide about using this finding. Now, structures are also now increasingly seen. So a lot of structural interventions are happening. So you should have a quick history, and this is easy. The patient either tells that they've undergone a procedure, or you'll have some sort of notes which tells you, and you should be quick to sort of identify this, especially when you have these small devices like the VST device here. So don't mistake it for some sort of unusual pathology. And here it is very clearly seen. This is a T image. So in transthoracic also it can be seen, maybe not as clearly, but when you see it, you should sort of be able to identify and report this. Now, the ASD device here, ASD devices, of course, are very prominently seen, and you do know about it. Just to sort of focus as in this list, so this is a typical ASD device. Again, this is from the T, so you have the transthoracic appearance, which looks different. And the true view image again tells you, gives you some sort of fantastic sort of findings. Again, it gives you some amazing sort of clarity as to how the image looks like. And again, using the light source, you can see it both from the LA side, the right atrial side, and it can be helpful using this true view when we're suspicious of some clot, or when you're suspicious of some infected endocarditis which has affected the device. But that aside, just to tell you that how the true view really sort of gives you some magnificent images. Then the smaller devices. So you have the patent foramen ovale device. So here you can see these are small devices, very tiny, small ones, and you can see the clarity which gives you in terms of how the two discs are, and you're looking at it from different angles, and you're using the light source. You can see the device which is in place on the either side. You have the two discs. So the devices which are used for closure of patent foramen ovale. So that is something which you should be careful when you're looking at the interatrial septum. So coming to the last slide, so this is how you should be looking at. So you have these normal variants. You can see them on a routine basis. So when you do see them, go chamber by chamber, and then in each chamber you have your own mental list of what is the usual variant structures which you see, and then you sort of mentally tick them off, or exclude or include them, and you can either report it when it has some sort of a clinical importance, or you need not report it. You can just ignore it if it doesn't have that much of prominence. For example, if it's a Crista Terminalis, you don't have to report unless it's really prominent and then there is some arrhythmia. It makes sense. Otherwise, you don't have to. So, ladies and gentlemen, so this is my final slide, and these are the structures which you have to be aware of. And this is how you should be categorizing the normal variants which can be mistaken for some pathologies or for some other structures. And of course, you have the artifacts also which can give you some sort of a confusion. Thank you. So I'm open for questions.
Thank you, sir. That was a wonderful session, and a lot of compliments that have flown into my window, because we've just enabled the chat. People can start posting their questions. I have the first question, sir, from Dr. Shanmuga Sundaram. He's asking, split IVS kind of appearance in plaques, is it moderator band of RV?
The split IVS has to be, that's a separate pathology. So when you look at the moderator band, it is a very clear course. It has an oblique course. It goes across the right ventricular cavity, and it starts from the interventricular septum, and then it courses down towards the RV free wall, and it's a linear structure. So it's not going to have any ecolucency, and the anatomical course itself should tell you that it is a moderator band, and the interventricular septum is in a different plane altogether, in a different area. So I would say that that's how you should first exclude and make sure that it is the moderator band by using these findings.
So the next question is from Dr. Kaushal Jani. He's asking DD of compaction and trabeculation prognostic significance in cardiomyopathy. Can you comment?
Yeah, this is something which I really don't want to go into because it's a separate area altogether. There's a lot of confusion. a lot of gray areas. When you see tuberculations, are they normal, or are they hypertuberculated, or is it LV non-compaction? So we have a tendency of over-diagnosing LV non-compaction because the imaging has become so good, and we are also aware of this entity, but we have to be very clear before we sort of try and associate it with LV non-compaction. You have these various criteria which are there, and we have to have additional imaging modalities before one arrives at a conclusion that it is LV non-compaction. So if you have the facility, use the option of contrast echo. So you can use the different criteria, the Jenny's or the Chen's criteria in systole and diastole. So generally the non-compaction will be more, and then the compacted area will be less. So that is a cross area, and then the area where it is seen also. So use of contrast before one makes a definitive diagnosis, and use of MRI also when one has to have real confirmation. That's how one would look at it. Otherwise, if you do see it, you can say that increased tuberculations, and if you are very clear, you can say non-compaction. If you're not sure, you can say it's a hypertuberculated area, and query non-compaction, you can put a question mark. But the tuberculated area, the message here is when you see it, the problem is the pain points are usually that you associate it with some thrombus, and that is the point where you show the message I'm trying to drive it across, is that thrombus, when you give contrast, is going to be very dark, unlike the tuberculated area, which is not going to be dark, and that's how you separate it out. So that would be how you can look at the tuberculations, looking at the LV non-compaction, and how to separate it from the thrombus.
So the next question is again from Dr. Sundaram. He is asking how to differentiate vegetation from LE.
The vegetations from
LE.
Lambel's excretions.
Yeah.
Okay. So this can be quite difficult, and usually the problem is when you have a typical patient with a high clinical suspicion of fever, and the usual works that goes with the clinical presentation of infective endocarditis. This is a common problem which I continue to see. There is no clear answer for it. Because vegetations also can be thin, also can be sort of oscillatory, can sort of vary in in its movement. But if you see the structure close to the coaptation point coming from where the leaflets meet, there is a high suspicion that it is going to be Lambel's excrescences, and this is usually seen in the older people. And if you see the structure which looks, you think it is Lambel's, but if you see it is attaching in the body of the leaflet, it's more likely to be a vegetation. At a certain point, it will be difficult to differentiate, and then you can give a differential diagnosis, and you just follow it up and probably do serial sort of imaging. But that is the extreme scenario, and this is how one can at least try to differentiate it.
So next question is how frequently does one need to follow up echo in interatrial septal aneurysm?
The follow-up, there is no recommendation, no sort of line which says that if a patient has atrial septal aneurysm, they need periodic follow-up. No, there is nothing like that. You just have to, if it is just like, let's say the patient has come for a health checkup or just for a routine echo, and you do see it, you make a finding, and then you sort of make sure that there is no PFO, there is no mass, just as a ruling out, and then you report it and you close it. But if there is a future event in terms of a CVA or in terms of a TIA, then it will be worthwhile to repeat it. But there is no expert document which says that atrial septal aneurysm you have to keep doing echoes, nothing like that. It is more on a clinical judgment, one has to take this call.
Sure. So next question is how to interpret smokes in RA and LA.
Sorry?
How to interpret smokes in RA and LA?
Smokes in, that is, I think, what is being meant is spontaneous echo contrast. Is that the question? Smokes in LA and RA.
Yeah, that's what is written.
So generally, when you see spontaneous echo contrast, if I'm assuming that is the
Yes, he's saying yes. He's asking the same thing.
okay. So usually sec or smoke is something when you see it when there is a dilated chamber. So the atrium has to be dilated. So that is the first criteria. So when you have a large dilated chamber, then that's when you have slow movement of the blood, and that's where you have the stasis, and that's when the smoke and the sec appears very prominently. And of course, when you have atrial fibrillation, so this again is another area. So that's how you sort of say that there is a sec, and if you increase the gain, if you do see it, you make a mention. And primarily, if you are going to associate with the sec, it is going to be a dilated atrium. So whether it is right atrium or left atrium, it has to be dilated, and usually see it more often in the left atrium. So that's probably the closest I can give an answer to that.
So the next question is from Dr. Prashant Gunasekaran. He is asking, why does posterior mitral annular gets calcified most often?
It is again the anatomy here. So it is one is the fibrous side and the other one is a muscular side, and the calcium has this predilection to get deposited because of the anatomical variation. That's why you don't see it on the anterior side, and it is more often on the posterior side. So even when you look at it, when they do a mitral valve repair, when they put the ring, it is always going to be the posterior mitral annulus. So that is why the mitral annulus, because of the disparity in the tissue which is seen. So one is the fibrous side and one is the muscular side, and the calcium tends to get deposited in a preferential manner, and that is why you see it more often. Sometimes you also see it on the anterior mitral annulus. That is because of some inherent metabolic issues where even the anterior mitral annulus can get a lot of calcific sort of deposition, but the predilection for the posterior mitral annulus is because of the anatomical variation.
Sure. So the next question is from Dr. Sharda Indrashekhar Roy. He's obviously, there are a lot of compliments coming your way. A couple of your students are also attending the session, and they are saying they're proud to be your students. His question is, may we be misguided to differentiate sometimes between Chiari network and Eustachian valve
Yes.
in PTE only?
Yes, PTE, it can be a double-edged sword. We have pulmonary thromboembolism. Now, actually, there have been literature publications which says that the Chiari network, it's as you saw in one of my earlier slides, it's like a leaf-like structure, and it has these small fenestrations. So it can actually act as a barrier. It can sort of take a thrombus and sort of hold it. So that is one advantage. That is the positive side of the Chiari network, where it can act like a barrier and can hold a thrombus. While on the other side, it can also be an initiator of thrombus. If there is an increased sort of hypocoagulable state, or for some reason the thrombus tends to stick over there and grows over there, it can also sort of initiate a thrombus from there. And especially this can be a problem when you have lines which are put in, whether it is a central line or some sort of a catheter, and it sort of abrades the tissue over there, it creates a raw area, and that's where it sort of originates. So the Chiari network, if it is there, so it can act both ways. It can be an initiator or it can be a controller of the thrombus. That is on one side as far as thromboembolism is concerned. It also, going beyond that question, it has also been associated with some arrhythmias. It has been a problem sometimes for some interventions where it can sort of get the wire tangled inside it. So if you see a prominent Chiari network, and if the patient is going for a procedure, do report it that you see it so that the interventionist is ready. So you have these different scenarios, and that's how one can look at pulmonary thromboembolism. And you can look at catheters which are there. I have seen quite a few patients where catheters have been put, and that itself has created a thrombus. So that's how the thrombus and then the Chiari network eustachian valve association is.
Sure. So next question is, what's the relation between DM patients and mitral annular calcification?
Could you please repeat that?
What's the relation between DM patients and mitral annular calcification? I don't know if it is diabetes.
Yeah, it's probably, I think, diabetes. So generally, it is something again to do with the metabolism which is involved. So you have the aging is one. Atherosclerosis, it's supposed to be again a marker of atherosclerosis, and of course we know that patients who are diabetics have increased atherosclerosis risk. So that would be the association between diabetes and the mitral annular calcification. So it is not a great sort of high on the list to say it's a marker, but it has shown association. So that's how diabetes will come into the picture, and you also see it in patients like renal dialysis patients where the calcium metabolism goes for a toss, and that's where you see increased sort of calcification. And sometimes when you see it prematurely, you'll see it in 40, 50-year-olds. That's when you have to report it. So then possibly it is again left to the clinician. Maybe they need to be a little more aggressive in terms of working up a patient for atherosclerosis, especially if the patient has diabetes.
So the next question is how to differentiate between lipomatous IAS and myxoma.
The typical myxoma, you can get atypical myxoma and then you can get typical myxoma. So the typical myxoma classic description that is described is that it has got a stalk, that is, it is pedunculated. So that is the first and foremost. And the second is it is usually attached at the interatrial septum. So if you see a stalk and if you see it is attached to the interatrial septum, and the third is it is mobile. So these are the three classic sort of descriptive features of myxoma. And while the lipomatous deposition is along the line of the interatrial septum. So you saw that the interatrial septum goes along a certain anatomical course. It is sort of has its direction. So you have the limbus that is on either side of the fossa ovalis. So that's where the deposition takes place. And usually sort of generally it tends to get deposited uniformly on either side. And it is, the other feature is that it is very bright. So this is how you can differentiate from a myxoma. So myxoma, mobile, has a stalk, and it is coming from the interatrial septum, projecting out as a mass, while the interatrial septal hypertrophy is just along the course of the interatrial septum itself, where it thickens and very bright. It's very echogenic.
So the next question is how to differentiate between lipomatous, how to distinguish between lambile excrescence and vegetation.
I think somebody did ask me that question, so just to sort of repeat it. So lambile excrescence, you can, first and foremost, is if you have a patient who's just come for a routine echo, there is no clinical background of an infective endocarditis, and when you do see the structure, you know that you're not dealing with the vegetation and it is lambile excrescence. So the clinical presentation is first and foremost very important. Secondly, if you do see the structure and if it is coming close to the coaptation point, and that is where the leaflets meet each other, that is called as a coaptation point, and that is where the lambile excrescence comes. And if you see a structure coming at that point, then it is more likely to be lambile excrescences. So if you see a structure in another place, and if there is a clinical background, then it is more likely to be vegetation. But you can also have these extreme scenarios where you can have clinical scenario of infective endocarditis, and then maybe beyond a certain point, maybe another imaging modality would make a difference, like maybe a PET-CT, so to really differentiate it. But it is, the clinical presentation is important, and secondly, the coaptation point. So that would be the separating feature from vegetations. Both have oscillatory free sort of movement, and both are very thin, can be thin, or as far as lambile is concerned, very thin. And that's the differentiating factor. But beyond a certain point, I think an additional imaging modality would be required.
So the next question is from Dr. Anshuman. He's asking how to differentiate between true LV aneurysm and pseudo aneurysm through 2D echo.
True aneurysm, okay, it is a little different. It is actually a pathology, not a normal variant. But just to answer that question, you have an aneurysm which has to have anatomical sort of, there are some very classic differentiating features. So when you talk about a true aneurysm, that means that the myocardial tissue, there is a continuity of that. So there is no break in myocardial tissue. That is the first and foremost. In a pseudoaneurysm, what happens is that there is going to be a break in the myocardial tissue. So there is a definite sort of lack of tissue between the cavity and the pericardium. So there is going to be a passage between the cavity and the pericardium. That is that's one point. Secondly, look at the neck. So if you have a very narrow neck, that is very classic of a pseudoaneurysm. And when you talk about a true aneurysm, they have a wide neck. So if generally they compare it with the cavity, the size of the aneurysm. So if it is less than 50%, it is likely to be true. If it is 50% or more, it is likely it's going to be pseudo. If it is likely to be more than 50%, it is likely to be the true aneurysm. So a true aneurysm and a pseudoaneurysm is different entities. So true aneurysm, you have the myocardial continuity over there, and it has got a wide neck, while a pseudoaneurysm has got a break in myocardial continuity, and it's got a narrow neck, and this has got a greater fatality, and it has some sort of communication with the pericardial space.
So the next question is from Dr. Monica. She's asking, a picoseptal muscle bundle, is it a normal variant?
You can get a lot of these accessory muscle bundles, and the first and foremost is if you do see it, just check the clinical background of any arrhythmias, or if there is a possibility of hypertrophic cardiomyopathy. But otherwise, if you see a muscle bundle which is sort of going across, and you sort of have ruled out that it is not a mass like a thrombus, then you sort of try to trace that accessory muscle bundle, and if you have again the contrast, you give contrast and try to delineate this muscle bundle a little better, and then that will give you clarity that it is something which is not anatomically normal, and that is something which is like an accessory sort of an area where you are not seeing it, and it is not some other mass, not some other pathology. And then when you sort of separate it out based on this, then you can say that it is likely to be an accessory model. They can sort of go in different directions, but the use of contrast, I think, can help out to a large extent to separate it out.
So the next question is from Dr. Vinod Vijan. He's asking, should we use TrueView in most cases because it looks like real, it will appeal to surgeons?
I would, I sort of use it almost in all patients, especially when there's a pathology, and invariably it gives me a good sort of a feel, and I'm confident in what I'm sort of seeing. So I think there is a true value in it, and just to answer the question simple and straight, yes, I sort of use it in especially in TEs where I use it almost in all the patients. I try to get a true view as one more acquisition and one more viewing, and it gives me incremental sort of information, and it gives me confidence in what I'm seeing.
So then there's a follow-up question from Dr. Gunasekharan. He's asking, are we being much more trabeculated? Why we don't see RV thrombus quite often compared to LV thrombus? Are we missing RV thrombus sometimes?
Yes, it can be a problem because RV shape itself can give you misleading sort of views, and it all depends on how you cut it. So if the thrombus is in a different plane, and if you're cutting it in a different plane, you might miss it. Or this is something which is a problem with RV, definitely, I would sort of say. And you can use the contrast a little more, and that is one. Secondly, try and sort of go for off-axis views, especially when the suspicion is high. You have to try going beyond the regular views which you see, and look at it from different angles. And try and sort of separate it out from tuberculation or whether it's a thrombus. But you can sort of miss small thrombus and you can sort of mistake it for a tuberculation, or it can be vice versa. So probably I think in this setting, I would suggest that when there is, when you're unable to sort of discriminate it, use of contrast. And once you use contrast, and if you're able to hit it, you can very clearly sort of make out by the contrast. It looks very dark, and is a thrombus, and it's not a tuberculation. So that is a problem which is there, and I would suggest that one can use contrast to see whether you can separate out that problem, the solution.
So the next question is from Dr. Monwar. He's saying the PFO you showed had left to right shunt, but the usual teaching is that PFO has got right to left shunt, usually demonstrable during maneuvers like cuffing, Valsalva, etc. So how can we differentiate between ASD and PFO?
Yes, the integrated shunt, it all pressure in the atrium. So if you have a pressure in the left atrium, which is more, again, you're going to right shunt and flow. So if you hello?
Yeah, there is a bit of a lag, sir.
Yeah, okay.
Can we request all the participants to stop video, because the bandwidth then gets shared and it will interrupt our chat. So I'll take up the next question, sir. In RHD, how do you differentiate from old lesions from new to say active carditis?
Okay, again, it is not related to this session, but in a rheumatic heart disease, of course, if you're looking at acute rheumatic fever, the incidence is quite low. You don't see it that often, but they come with a classic presentation. So there has to be a clinical criteria. You have to sort of look at the clinical features, and then the investigative features are there. And then if you do see a patient who is unaffected, and if you see a very thick leaflet, that is the edematous leaflet, and the mobility is not going to be restricted in terms of a patient who's been unaffected by rheumatic heart disease, so there's no stenosis as such, and a thick leaflet which looks very edematous, and there's going to be regurgitation. That's one sort of setting where patient does not have any background of rheumatic heart disease. Now, the problem happens when there is an existing rheumatic affection. So there is, let us say, rheumatic heart disease, which has affected the mitral valve, and then there is some sort of stenosis or some restriction is there. And on top of it, you have the rheumatic fever. So you can get the edema again. So what will happen is the leaflets become very edematous, and they appear to be they look very thick. And one can look at the TE as an option, as an alternative. We have had a couple of scenarios where there were patients with pre-existing rheumatic heart disease who came very surprisingly with acute rheumatic fever, and we were able to separate it out. So TE in those instances really sort of proved to be beneficial, where one could look at the uniform thickening of the leaflets, and that clearly suggested that it was a very inflamed and edematous leaflet. And then again, for correlation, we asked for another imaging modality, MRI, which sort of confirmed. So I would say that uniform thickening with a clinical background, possibly very high suspicion of the rheumatic fever affecting the leaflets.
So the next question is from Kirti Dikshit. She's asking, is there any characteristic feature we should look at to differentiate between pectinate muscles and thrombus or mass?
The characteristic feature of pectinate muscles are that it will have, on 2D, if you're doing 2D, it will have a very sort of linear appearance. So that means you've actually sliced it through those muscle sort of ledges. They are like shelves. So let's assume that you have a series of racks in a shelf, and each rack will be a pectinate muscle. And when you do a 2D, you're taking a slice. So then what happens is these racks as shelves, which you see on 3D, you're not able to appreciate in 2D. They will appear like, the teeth in a comb. So if you have a comb, if you've seen the teeth, they'll be like projections which are coming out. So these are characteristic features of how the pectinate muscle looks like. And of course, if you have the 3D, you can always fall back. Now, let's say that you don't have, and then you are not sure whether it's pectinate muscle, and you feel that you want to separate it out from a thrombus. Again, the next best is to look at in the use of contrast. So contrast can usually sort of have the sort of clarification where you can the thrombus gets sort of delineated very clearly, and the thrombus does not have a linear, sort of very rare for it to have that linear type of appearance. So it will have some sort of a roundish or irregular shaped, and it's going to be mobile and in a different area. So that's how you sort of try and separate it out. So teeth-like, comb-like sort of structures going in a uniform sort of spacing and in the left atrial appendage, and use of contrast to if there's a need to separate it out.
So the next question is from Dr. Saklani. He's asking, it's a comment and a question. Epicardial fat is equilucent or echogenic. Is it atherosclerotic risk factor?
Okay, so one is that I take the first question. Now, epicardial fat is something like a tissue-like thing. While when we talk about pericardial effusion, it is nothing, but it's like a watery consistency. So it is always going to be dark. So when you want to compare let us say that you see something which you suspect it is effusion, compare that epicardial fat or that suspected area with the cavity. And if there is equal sort of lucency, both in the cavity as well as the area where you suspect there's an effusion, then the risk and then the chances of pericardial effusion is more. So the usual trick is, one is location. It tells you that it's more towards the right side, and increase the gain a little bit, and then you get to see the granularity a little better, and use the zoom or the focus so that you can focus on that particular area. And once the granularity comes in place, now the fat is going to stick to the myocardium. So whenever the myocardium moves, the epicardial fat also moves. So it moves with cardiac cycle, which you don't get to see it in pericardial effusion. So those are the separating sort of points. Now, coming to that point, there has been a lot of interest from quite some time as to whether one can use the epicardial adipose tissue as a marker of atherosclerosis. It has been associated. There has been a lot of work on it, but it's not again high on the list. There has been publications in the CT also where they have looked at it. So definitely, if you do see it very prominently, you can mention. And again, it's a question of how to correlate clinically. So if a patient who's got a background of family history of coronary disease, then possibly it may have significance. And also ultrasound of the abdomen, also one can look at the fat in the liver. So it's a lot of correlation one has to make, but it's a finding when seen prominently, you can report it, and that would be the association.
So Dr. Manohar Reddy is asking a very pertinent question. What is the sensitivity and specificity of TrueView 3D compared to cardiac MRI?
I really cannot recall a study which has looked at it. It may have been published, but I'm not very sure about it as far as sensitivity is concerned. But in a different perspective, so there was a study which looked at a series of TrueView images, and clinicians were sort of grouped, and then they were shown these images, and then they were shown the regular 3D, and then the TrueView also. And what in that small study, it was more like a exploratory sort of pilot study, showed that the incremental information in making a clinical decision was higher when with true view images. So that is the value of it. As far as MRI true view, I'm not really sort of sure about it. Hello?
Sorry, I was on mute. The next question is, in RHD, how do you differentiate from old lesions to new lesions? Oh, sorry, this I took.
Yeah.
I'm sorry. Let me just quickly. Can TrueView help us in differentiating vegetation and fibroma from each other?
Both are sort of masses, and vegetation generally, is seen on the leaflets. You have a clinical presentation. So the two comparisons of a fibroma and vegetations may not have that sort of correlation. So you have anatomically different sort of places where the fibroma happens and then the vegetation happens. And then you have a clinical setting of fever and all those things where you have the infective endocarditis. So, I would look at it that way. So the clinical setting and then the structure involved, and the fibroma is more like a different place, and you need to sort of you can delineate the structure, but much better with TrueView. But the clinical presentation is what is important as far as infective endocarditis and fibroma is concerned.
So the next question is how to see LV thrombus in LV non-compaction.
That again is fairly straightforward. So a lot of publications on that. The sensitivity is quite high, almost I think around 90%. Use of contrast. So since these patients have a high risk of thrombus formation in the spongy area and high risk of embolization, it has been even reported to coronary arteries also. At any point of time, I would really push the use of contrast, though there are two things which is always given as a reason why contrast is not used. One is the cost, and then second is the logistics of putting an IV line. So those are the things. But when you have a situation like this, where you really need to separate out thrombus and in a non-compacted patient, use of contrast can sort of clearly will tell you, because moment the contrast goes inside the left ventricular cavity, it delineates the mass, it delineates the thrombus, and one is that the contrast is not taken by the thrombus. It is an avascular structure, so it will appear very dark, unlike a trabeculation. So that's how one can separate it out. So use of contrast can really be helpful in a scenario like this.
So I'll take this last question. What is the normal thickness of epicardial fat in 2D echo, and what is the maximum thickening observed in atherosclerosis, especially in the plaques view?
Again, I don't actually sort of recall the normal values, but I would say somewhere around anything more than about 3 to 5 millimeters possibly would be something which one needs to be a little sort of concerned. So definitely anything more than 5 millimeters would be suspicious. There are some values, but I really don't recall it right now. So I would probably take probably, if I'm not so sure, but I would say possibly something around more than 5 millimeters, but then anything more than that would be saying that it's increased deposition.
So there's one last question, because Dr. Vijayan Joseph has posted this twice. How to differentiate between tricuspid annular lipomatous hypertrophy from tricuspid fibroelastoma?
The papillary fibroelastoma usually comes from the leaflet, and it has a different echogenicity. It is not very bright. And the papillary fibroelastoma has got a stalk, and it is mobile. So the echogenicity is one, and the mobility is the other thing, and the location of the structure also. It is more associated with leaflets, while the lipomatous deposition is confined to the annulus, and you'll see it only in the area where the annulus is. And it can affect on the entire annulus or on one side. That is one. And it's not going to be mobile like a papillary fibroelastoma. it is going to move with the annular sort of movement, unlike a papillofibromatosis, which will be moving, which will be highly mobile. And the third is that the echogenicity of this tissue is quite bright. So that would be the separating sort of factor. I sort of hope that this lockdown ends as fast as possible, and stay safe, and then let's get back to normal life hopefully in a week or so. So all the best to all of you. Take care, and thanks Phillips for this wonderful series of educative webinars. I think a lot of people are benefiting, and I think you guys need a lot of appreciation, putting in a lot of effort.
Thank you so much, sir. We thank all the participants. Wish you all a great Sunday. Enjoy, keep learning, stay safe.